Welcome to Respiratory Core 2017. This week's topic is the difficult airway. These are some of the objectives from the Royal College National Curriculum pertaining to difficult airway. We will be focusing on the ASA practice guidelines for the management of difficult airway, as well as that published in the Canadian Journal of Anesthesia. The definition of difficult airway varies across literature. It is defined in ASA as when a conventionally trained anesthesiologist experiences difficulty with airway, whereas in the Canadian Journal of Anesthesia, it is defined as when an experienced provider anticipates or encounters difficulty with airway management. The table below shows various categories of difficult airway as defined by the ASA and CJA. Important differences are highlighted. CJA defines difficult laryngoscopy as a grade 3 Cormack-Lehane view and a failed laryngoscopy as a grade 4 view. Also, CJA defines failed intubation as failure with a maximum of 3 attempts, while the ASA simply states failure after multiple attempts. The ASA Guideline Recommendations for difficult airway include the following. Airway history and physical should be completed in all patients before initiation of anesthetic care if possible. Findings will further guide special tests to evaluate the airway. Basic preparation for a difficult airway include a portable difficult airway cart that is readily available, and if the patient has known or suspected difficult airway, 4 steps should be taken. Number 1, inform the patient. Number 2, ensure the availability of assistance. Number 3, pre-oxygenate via face mask. And number 4, actively pursue opportunities to deliver supplemental oxygen throughout airway management, such as blow-by, nasal cannula, face mask, or LMAs. Intubation strategies should be pre-formulated, considering potential difficulties at each step of the intubation process. Important choices such as asleep versus awake, non-invasive versus surgical, video laryngoscopy versus direct laryngoscopy, and patient being spontaneously ventilated or apneic. And also consider 3 important clinical situations, such as awake intubation, cannot intubate, can ventilate, and cannot intubate, cannot ventilate. Surgery under local and regional may be an alternative, but this does not represent a definitive solution to the difficult airway and does not obviate the need for a pre-formulated strategy. Confirmation of tube placement should be done with end-tidal CO2. The difficult airway algorithm of ASA is an example of a pre-formulated intubation strategy. I will leave it to you to review this in detail. The extubation strategy should also be pre-formulated, considering important factors such as awake versus asleep extubation, clinical factors that may adversely impact ventilation after extubation, airway management plan if the patient were unable to maintain adequate ventilation, and short-term use of devices to guide reintubation, such as exchange catheter or intubating LMAs. Follow-up care should be done for patients with difficult airway. This includes documentation of reasons for difficulty, how intubation was accomplished, and implications for future care. We should also inform the patient by documenting in the chart, writing letter to patient and surgeon and family doctor, as well as flagging the chart. Follow-up with the patient for potential complications should also be done. Complications may include edema, bleeding, tracheal perforation, esophageal perforation, pneumothorax, or aspiration, and we should advise the patient of signs and symptoms of life-threatening complications, such as sore throat, facial pain and swelling, neck pain and swelling, subcutaneous emphysema, or dysphagia. The Canadian Journal of Anesthesia Difficullt Airway algorithm has a specific section for unanticipated difficult airways. The salient points are highlighted here. Specifically for emergency surgical airway, in cannot intubate, cannot oxygenate situations, if supraglottic device is ineffective, immediate cricothyrotomy should be done without further attempts at the supraglottic device or tracheal intubation. For emergency cricothyrotomy in adults, unless very experienced at jet ventilation, limit your options to needle or open cricothyrotomy. In patients with poor landmarks, consider beginning the cricothyrotomy with a 3 cm vertical midline incision. And, finally, even if not indicated as part of the initial management, once in a cannot intubate, cannot oxygenate situation, consider administering or redosing neuromuscular blocking agents to address possible laryngeal spasm and to facilitate face mask ventilation. This is the Unanticipated Difficult Airway algorithm published in the CJA. Key points include the following. Patient's morbidity increased with the number of attempts at tracheal intubation, and therefore 3 failed attempts at tracheal intubation should be taken as an indication to declare a failed intubation situation. This is when we should pause and consider exit strategies. The goal of engaging an exit strategy is not necessarily to prohibit more than 3 attempts of intubation, but it is to serve as a warning that further attempts may be complicated by increasing patient harm and decreasing chances of success. This is the Unanticipated Difficult Airway algorithm for obstetrical patients. Once the need for general anesthesia becomes apparent, the attending anesthesiologist should perform a formal airway assessment of the obstetrical patient, including localization of the cricothyroid membrane. For induction of general anesthesia, appropriate patient positioning and pre-oxygenation should occur. And while waiting for the onset of neuromuscular blockade, face mask ventilation can occur with low insufflation pressures of less than 20 centimeters of water. After failed intubation during emergency C-section, if proceeding under face mask or supraglottic device ventilation, the obstetrician should be requested to make a generous surgical incision and to minimize fundal pressure or use vacuum extraction at the time of delivery. In any airway rescue scenario in the parturient, the early use of a supraglottic device should be considered. And finally, the Canadian Journal of Anesthesia makes several recommendations for unanticipated difficult airways in pediatric patients. Cuffed endotracheal tubes should be used in difficult or emergent pediatric tracheal intubation. There should be a cuff leak with less than 20 to 25 centimeters of water. For children less than 8 to 10 years old, in a cannot intubate, cannot oxygenate situation, help should be summoned, and if not already attempted, a supraglottic device should be placed while equipment is readied for surgical or needle tracheostomy. Below 10 years old, the cricothyroid space is underdeveloped to accommodate cricothyrotomy. Thank you for listening and have a great day.